Good evening, everybody. It is Dr. Tony Hampton, as you know, a board-certified family and obesity medicine physician here with a post-podcast discussion. I, along with my guest, who you see right next to me, Dr. Adele Hite, and I just recorded episode number 5 of the Protecting Your Nest podcast. Totally excited about that. And that'll be in the podcast app store on Friday, July 31st. So it's coming up next week. In the show notes, we'll make sure there's a link for you guys. And you know what? No need to wait for the podcast because we're going to have a conversation right now. During the podcast, we talked about clinical guidelines, basically a prescription for a carbohydrate restriction. In other words, how do we teach our clinical teams how to reduce carbs in our patients and do it in a way that everybody's on the same page? We also touched on whether those guidelines, those dietary guidelines, can help people of color as they begin to try to improve their metabolic health. So during our live section, I want to dive a little deeper into social determinants of health. I know we just talked about that with President of Advocate Aurora Trinity and South Sub Hospitals in Chicago, Rashard Johnson. So episode number 3, we talked a little bit about that, but I want to dive a little deeper. And I think this is a very good time to talk about this topic. So let me welcome my guest, Dr. Hite. And if you know anybody that needs to hear this information, share this video on YouTube. And of course, you can share right now on Facebook. And if you have questions, just put those questions in the comment section and we'll try to get to some of those as well. So Dr. Hite, people need to know who you are and why you're a guest on my podcast and now this Facebook Live. So give me an idea of what your background is so my audience will know. Tell us a little bit about who you are.
Sure. And thanks for having me. I'm a registered dietitian with a background in public health, master's in public health. So I'm familiar with all of the kinds of programs that people who get their food from federal nutrition programs that the Dietary Guidelines dictates. So I'm familiar with those programs from my public health background. I got my PhD in communication, rhetoric, and digital media when I realized that the way that we learn about nutrition and the way that we communicate about nutrition are central to how we think about what a healthy diet is, more central than perhaps we're even aware, that most of our nutrition information comes from food boxes, comes from the media, comes from the internet. It doesn't come from clinicians, although clinicians are a trusted source.
So communication rhetoric is how we message and say things so people can understand. I just want to make sure that's clear. Okay.
And the other neat thing about that program is that it's not just about how we say things, but it's about what words do.
Yeah.
So when I was writing my dissertation, which I wrote on the Dietary Guidelines for Americans, our national nutrition policy, what I began to realize in my research is that the dietary guidelines were a way of making individuals responsible for their own health outcomes. And this is always a tricky topic.
Wait a minute. The guidelines, I thought were a way to tell the clinicians and other people. I mean, I thought that was their job to then guide us. You're saying it's our responsibility?
Yes. So the dietary guidelines, the public health dietary guidelines, were a way of saying. So what was going on is that we had instituted Medicare and Medicaid in the 50s when the economy was really strong. But now we were entering a period of economic instability. There had been bipartisan support for a national health insurance program. So you're probably too young to remember that, but there was way back when. And bipartisan support for a national health insurance program. And then we hit the recessions in the 70s. And all of a sudden, it was no more about expanding our healthcare coverage for Americans, but contracting it. How can we reduce healthcare costs? And the McGovern's Senate Select Committee on Nutrition and Human Health, they've done amazing work for feeding the hungry in the U.S., now turn their attention to how can we stay funded and keep our jobs and turn our attention to overnutrition, which is a term that they made up because they thought that by fixing overnutrition, that they would now have a way to prevent chronic disease and reduce healthcare costs. And what that did was, in the 50s and in the early 60s, we thought about health differently than we think about it now. We thought about health in terms of institutions and organizations and businesses. It's like the government was responsible for keeping environments clean and rivers clean and the air clean so that people could be healthy. It's one of the things that you talk about in ROPE, right? Pollution and exposures. And we know how that affects health. And businesses and organizations were responsible for making sure that their employees had access to healthcare through good and health insurance policies, right? And then all of that started to go away beginning in about the 1980s with Reagan, as we talked about in the podcast. Things really changed. But what these dietary guidelines were meant to do is to prevent chronic diseases that didn't currently exist.
So it was more prevention. It wasn't really treating people who had it.
It wasn't about treatment at all.
Okay.
And you have to remember that although our rates of obesity have been very slowly going up through the 60s and 70s, they were still quite low at that point in time. Okay. The rise in obesity didn't occur until after the dietary guidelines were created. But we did have our eye on one population that we thought was going to make our healthcare costs go way up. Okay. And as we talked about in the podcast, we had identified really high rates of obesity in poor African-American women. So women who were African-American and living below the poverty line had the highest rates of obesity in America. And this population was sort of targeted in terms of we've got to do something about these women before their eating habits, their bad eating habits cause our healthcare costs to explode. And the report that the Senate committee created actually targets low income and minority populations as in particular needing help to not be preyed upon by food advertisers. So the implication there is that for some reason, if you don't earn very much money or you have a lot of melanin in your skin, you can't resist food advertisers the way that white people can. So again, a very racially biased message, and that as a result, these populations needed specific targeting for nutrition messages so that they could learn how to eat right.
Wow. So these race inequities, that sounds like race inequities, just like when I started to teach a lower carbohydrate type of diet in my clinic for those who, I felt needed that, the first thing I had to do is to say, yes, you can. I mean, I had to believe that they could do it or that they would make a change, and to stereotype people and to just say, no, they're not going to do it. And it's just a ridiculous statement. It's just like, I always remember being at a conference where they had a speaker, and she was an overweight lady, and she asked the question. She said, so when you see me, what do you think, right? And then people were being honest, lazy, blah, blah, blah. And then she said, well, I've lost 150 pounds. So it's like this perception. Now, she's not lazy at all. She's, she figured out a path to do her thing. But again, we stereotype people. And that is a problem, because then just like when I walk into a store and somebody follows me around, so it's just to hear you say that is just amazing. So it sounds like your work is, it's not just about guidelines, it's about how these guidelines can impact certain communities. Yep. I am curious. I know in the podcast you talked about your dad and how he kind of inspired you to, get on this path. But when it comes to communities of color, why all of a sudden, what's your interest in that? Where did that come from?
Well, it comes from a number of different places, but it actually was sparked by a good friend of mine, a colleague of mine at UNC. So I was in a nutritional epidemiology program at UNC, and I got kind of hip checked out of there because, they'll have their story. I have mine, which is that they really did not care much for my questioning of the dietary guidelines.
Right.
And you have to experience those headwinds in order to really believe that they exist. So I'm always grateful that there was that pushback, because I don't think I would have believed that there was such institutional resistance to questioning even. So I'm not talking about changing or anything like that, but just asking the question.
Isn't that what scientists are supposed to do?
Isn't that what scientists are supposed to
questioning
do?
attitude, be a little skeptical. I mean, we learned all of this in school, but it's like they don't want you to apply it.
Yes. So I had a colleague at UNC who did her PhD research on a data set that followed minority teenagers and white teenagers as they progressed to adulthood. And what her research showed, and it was just a really startling conclusion, was that, first of all, everybody gained weight over time. So that's not surprising considering what we know.
That's right.
But even people who followed a healthy diet, according to the dietary guidelines, gained weight over time. Here's the interesting part. What she found out, her name is Daisy Zamora, what she found out is that the Black teenagers who ate a healthier diet actually gained more weight over time than the Black teenagers who ate a less healthy diet. Now, this is healthy as defined by the dietary guidelines.
Right.
So a
lot of grains and things like that.
A lot of grains,
Right.
lower fat.
That's right.
Lots of fruits and vegetables, maybe. But so she used the dietary guidelines as her definition of what a healthy diet is.
Okay.
And it was quite striking because it showed that, first of all, everybody gains weight over time, which shouldn't be the norm, but it was in her research. But that for the white participants, if they ate a healthier diet, they gained less weight over time. And if they ate a less healthy diet, they gained more weight. But the curve for the white participants is here, and the curve for the Black participants is here. So even Black participants who ate an unhealthy diet, which was better for them than eating a healthy one.
It's a crazy thing to say.
It is a crazy thing to say.
Eating all that dangerous meat.
Right. They still gained more weight than their white counterparts. So it doesn't matter how they ate, they gained more weight than their white counterparts, which points to a couple of important conclusions. One is that there's probably some background biological differences that track with race. So they're not necessarily race per se, but that can be separated out, at least grossly, by race. And we do know that from other research that that African Americans tend to metabolize carbohydrates very differently. Things like even measuring for metabolic syndrome. So when you go to track metabolic syndrome, what you'll see is this interesting thing is that African Americans don't have metabolic syndrome, don't have metabolic syndrome, don't have metabolic syndrome. And then when they get to adulthood, they have higher rates. Yes, higher rates. But there's a reason for it. And you may have seen this in clinic, is that the criteria that we use to define what metabolic syndrome is includes insulin levels, it includes abdominal obesity, it includes glucose levels, but includes two factors that actually track together. One is low HDL and high triglycerides. Well, a lot of African Americans don't actually express that dyslipidemia when they have high levels of insulin. So they may have insulin levels that are through the roof.
That nobody's checking, by the way.
Nobody's checking, by the way, because that's not considered an important criteria. But their glucose may look normal because their insulin is so high. They've got abdominal obesity, but they've just got obesity in general, and so that's sort of tracked as obesity. And they've got high blood pressure because a lot of African Americans have high blood pressure, so nobody thinks that's unusual.
That's right.
But they have normal HDL and they have normal triglycerides. So they don't experience the dyslipidemia that a lot of white folks have when they have. So they don't get tagged as having metabolic syndrome. And then years later, when they show up with diabetes and high rates of diabetes, their physicians in their health records, there's no evidence that they had metabolic syndrome earlier because we don't use the right criteria. And we've known about this for years. And as
We've
a result,
known about it for years.
oh yeah. This is in the literature. This is old hat in the literature. It's old hat, but we don't use it because why? Because they're not white people. I mean, they're not the majority. They're not the people who these criteria are based on. They're not the people who are in the research studies. They're not the people who get recruited for the research studies. We just simply disregard it.
Do you think that people of color would participate in research studies if they actually were asked more aggressively? I mean, is that, do you think that's really, because I know people have, you know, there's not always a lot of trust in communities of color. So I'm not going to be a guinea pig. So do you think people of color with the right education would actually be participate? Because that's not the whole problem from listening to you, but that should help to at least define. I need to know if your body is going to be metabolically different than your counterpart here. So,
well, I think if we could help educate communities of color that there are these discrepancies and that their communities are not being treated appropriately because we don't know what we don't know.
Right. We don't know what you don't know. So,
but the evidence of mistrust, the history of mistrust it's a real thing, and I think it's reasonable to mistrust the medical community and the public health community, considering the history that we've had with these communities.
Okay. What about so somebody listening right now may say, you know what, I hear what you're saying. I'm having some economic stress though. I'm on insulin. I'm financially, I mean, I have patients all the time who come in and they're on insulin that costs a couple of $100 essentially. Mm-hmm. And if they're struggling right now, what they do? I mean, where do they even start if they're having, we have pharmacists that may be able to help them, but man, what a frustrating world to live in when I have a condition until they do these changes in their carb restriction. They're going to need that insulin for a while. What do they do in that situation in our current society?
Well, I think that this is a civil rights issue because first of all, the fact that they're on insulin is because they haven't been given the care that they should be given, which is the option to not be on insulin.
Right.
So that this is, and again, if you are a privileged individual and you have access to a wide variety of healthcare, if I don't like what you tell me, I can go to somewhere else, right? And I've got the resources and I've got the social capital and the cultural capital to push back against the mainstream thinking, then I can go to my physician and I can demand, look, my neighbor down the street, he's on this low carb diet and he doesn't use insulin, and that's the diet that I want to be on. I want you to give me that diet. Now, how many of our communities of color have that kind of leverage within the healthcare system?
Yeah,
they don't.
Many, yeah.
And so as a result, they're not only given less access to healthcare in general, they are given less access to a kind of care that could prevent them from missing out, from having to avoid having insulin having to take insulin in the first place. So I think the revolution needs to be in the clinic. I think that patients need to come in and they need to demand, especially patients of color, they need to demand the same kind of care that anybody should be able to demand, which is that I don't want you to just manage my diabetes. I don't want you to just put me on medication that's going to maybe possibly slow down the progression of my disease. I want you to work with me to reverse my disease. I want you to work with me to put my disease in remission, because we know it can happen. And you can at least give me the option. Don't give up on me. Don't withhold that information from me just because you don't think I can do it, because low carb diets aren't sustainable. Let me have the information let me make that decision.
You gave me a flashback, and you may not know this, but before I'm essentially a family doctor who functions like an internist. But before I became that, I had done a fellowship in maternal child health. So I actually probably have been involved in 600 or 700 deliveries. I was a kind of an OB peds doctor, but I do recall, so we served, it was in the first suburb outside of the west part of Chicago called Oak Park. And in that suburb, literally I'm not making this up. The hospital had an entrance that faced what we call the Austin community. And that entrance, which is a kind of a poor, underserved community. Now, Oak Park's a wealthy suburb, right? They changed the entrance of the hospital. This is going back a while, so that it wouldn't face that community and it would be more in the other community. That's one thing. But I bring them up because I remember when I was working on labor and delivery, and I noticed that you would always see non-African-American patients being scheduled for their epidural, C-section, whatever. Yeah. But it was like they had a choice. They literally demanded, this is when I want to be delivered. It was like, going to the restaurant. Yep. You could never do that if you were like an African-American patient with limited resources. It was just never. And it was just such a normal part of the culture because the residents took care of that poorer community. And then the kind of like the attendings in private practice took care of it. And they would always say, patient coming in, and we were looking at the criteria for a C-section. It didn't seem like it was being met, So, so anyway, you gave me a flashback just thinking about that and trying to understand we live in a tale of two cities. And it's very, you want to think it's subtle, but it's not subtle. It's kind of in your face and we just accept it. So I think you're right. We need a revolution to kind of address these issues. One of the things that I was able to find about you was that you wrote Why Race Doesn't Matter in Nutrition Policy. So that kind of was the opposite of what I expected to say. So could you please explain what that piece that you wrote, Why Race Doesn't Matter in Nutrition Policy? I thought you just said the opposite just now.
I did. And the punchline is race doesn't matter because science doesn't matter. So the dietary guidelines are there not for scientific reasons, but for political reasons. And this is what my dissertation was about those political reasons. And those political reasons are race-based, they're economically based, they're culturally biased towards the way that well-educated, upper-income white people eat. Okay. They are, so we know, I think we have good evidence at this point that the dietary guidelines, when they were written to accomplish a lot of things, and they were covered with just the thinnest veneer of science. And most of that science was observational studies, so the weakest form of science that there is. But the dietary guidelines were meant to accomplish a lot of other things, not just tell people how to eat healthy. Right. The idea was to keep a cap on healthcare costs. The idea was to point a direction for health, for research. The idea was to give direction to food industry so that the food industry could begin to produce foods, more of the foods that would fit these dietary guidelines. So they knew all of that when they created them. But at the same time, there was an idea that if we just got poor folks, and especially communities of color with low incomes, to eat like wealthy folks, that we would be able to prevent these higher rates of chronic disease in these poor communities. Now, think about that for just a second. You had talked at the beginning about social determinants of health. Wealthier people, white people, well-educated people are already healthier, right?
Right. That's true.
They're already healthier.
Where I live in Oak Park, I promise you, they're just jogging and the kids walking around with celery and carrots and, it's completely different.
It doesn't even matter what they eat or whether or not they exercise. You're already healthier. Why? Because your mother was healthier. Because you live in an environment that is free or is more likely to be free of toxins and pollutants.
That's right.
Because you have lower levels of stress, because you're not worried about getting shot on your way home, because you're better educated, so you can make decisions about your health based on the information that you read and what you hear that you can't if, for instance, you had to drop out of school to go to work to help to support your family, right?
Yeah.
So all of that contributes. So it's not, again, one of the things that I learned in my dissertation that the dietary guidelines gave us is this rhetoric of choice, that you can choose good health by the behaviors that you choose.
Okay.
that if you just make all the right choices, that you can be healthier. Well, Daisy Zamora's research showed us that that's not the case. That you can have Black teenagers who choose a better diet, and guess what? They're less healthy, at least according to weight status. They are less healthy than these Black teenagers who chose a poorer diet. So if you're talking about research that doesn't apply to you in the first place, if you're talking about eating habits that don't apply to you in the first place, you're giving people through the dietary guidelines, the public health dietary guidelines, it's a double whammy on top of the triple whammy of poverty, of structuralized inequalities, and a history of racism in America.
What do you mean? Like, I think the average viewer, and maybe it's obvious to other people, but I think structural inequities, would you define that a little bit so the average person will understand what you mean?
Sure. These are the things that we don't recognize as being built into the system.
Okay.
So back in the days of slavery, the inequities, we could recognize them. We could look at that and go, yeah, that's not right. But redlining in terms of where you can live and how much capital you can hold on to, that wasn't obvious. And when people are told that they can only buy houses in certain sections of town, which means that their house will not build in value the way that other houses will, then that's a structural inequality that's hidden, that people don't even know about. When you get to things like you talked about this in the podcast, so those of you who are listening have to tune into the podcast for the full story about going off to college and having benefits cut off.
Yeah.
Because you went to college, so you got them through high school, but the benefits weren't going to be extended to college age kids.
That's right.
That to me smacks of a structural decision, so a political decision that says we're going to make sure that people who already don't have advantages continue to not have advantages, right?
Crazy.
And then the history of racism, I think we're pretty well familiar with that, but what we don't realize is how this affects health. So this is another thing that I learned from Daisy, right? Is that how do you explain the fact that a healthy, high carbohydrate, low fat diet is less healthy for this subpopulation? Well, if you're walking around being followed through stores, nervous about some trigger happy somebody shooting you because they think you're a criminal.
I still get so nervous whenever I interact with cops, and I have cops as patients, but it's just something in my brain that won't let me relax around cops because of what I see in the media. But you're right, and that's a stress.
That's a stress, and imagine if that stress is pulsing all the time, constantly. And think about if you are an African-American female who is with low income, the stressors in your life. You're worried about your kids. You're worried about just putting food on the table. You're worried about the bugs in your apartment. You're worried about getting your kids a decent education. Your stress level has got to be incredible. And then you get followed around the grocery store.
I know.
Then on top of all of those other things, you get followed around the grocery store. So these, and you have to worry about your kid, your son, your darling boy going out and saying the wrong thing to the wrong person and not coming home.
That's right.
Right. So these are constant insults to the body that can raise hormone levels, can raise insulin levels, can raise cortisol levels, can mess everything up in terms of your biochemistry. And we know that this is present. We know that from studying these subpopulations that the hormones that cause weight gain, the hormones that lead to some of these metabolic diseases or that have strong connections to these metabolic diseases tend to be higher in some of these people of color and especially women.
You remind me, some people are aware that I'm studying with University of Western States. So I'm doing nutrition and functional medicine. And they did bring up that term epigenetics. And so I'm curious if you could just comment on that, because it sounds like there's something going on with our genes. And I hadn't really in medical school, if they talked about it, I probably was sleeping in that class, but we really didn't talk about the connection between environment and really this whole nest and rope ideology is about what are the root causes of things that can affect our genes and how we express things. So tell me a little bit about epigenetics. So I want people to hear that term and understand a little bit.
I think epigenetics is really, really important in this discussion because it's sort of the bridge between the things that I can control about my health,
right?
Diet, exercise, sleep, and then the things that maybe I can't control about my health. And it's not just genetics. So the beauty of or the dangers of epigenetics. So our genetics, our DNA is a code. It's an imprint. Boom, boom, boom. Nothing changes, right? But imagine if we're writing all day and our hand is cramped up, right?
Right.
So our hand is still there, but it's not working the way that it's supposed to.
Right.
And it's going to take generations upon generations to get down to that genetic code being the way that it is. Now, think about a Black family whose origins were in slavery, right? And think about the insults on that family. And this is especially true with regards to maternal health. And there's some interesting repercussions that continue to this day. So you might have times of feast, and then you might have times of famine.
Right.
You might have times when you could barely feed your family. Your family could be taken away from you. You could be separated from your family completely. The trauma that's associated with that. Think of all of that being like your DNA is like this. All right. So this is not, your DNA is still there, but it doesn't work the way that
it's not going to work well.
And what we've found out for African-American women is that even after they break out of cycles of poverty and they're educated and they're living middle-class lives and nice houses in the suburbs, they still have smaller birth weight babies. They still have much more problems with delivery, with prenatal just complications, and they have higher level of infant mortality that are associated with, and these are middle-class women, these are well-educated women, but those epigenetic effects, which are especially carried on for maternal health, are still there. Those years and years and years of insults and trauma, we hold them in our bodies. And it doesn't go away in a generation.
And so when we learned that, that's a good point. So keep going.
Well, when we look at people,
let me just say this real quick. So what I learned is so you do have genes you're kind of inheriting from your family, but then, just like COVID, mutation, right? But once that mutation occurs, which may be because of some environmental factor, it carries on, not only in your life, but because every time you replicate the DNA, you're replicating this mutated, nucleotide strand of DNA. So it's almost like you can see how it can carry not just with that person, but it can go to the next generation and the next generation.
Right. Well, the part about epigenetics is that the DNA underlying structure is not affected. So there's no mutation. Nothing. But what happens is it's actually environmental effects. So you were taken away from your mother as a baby. That's one cramped up finger. You were not fed on a regular basis growing up and through your adulthood. You went through cycles of famine where there was no food for the family. Well, now those fingers don't work either. And maybe as an adult, you're traumatized by the fact that you can't walk safely through your neighborhood. Now, all of a sudden, your hand doesn't work. Okay, it's there. It's possible. There's no mutations. The hand is still there, but that doesn't work. And these epigenetic effects get passed on and replicated. So it's almost as if the genes are actually mutated, but they're not. So there's a possibility for healing down the line. But think of all the things that we have to change in order to get that healing to occur.
There's too many factors. I tell my patients, even as I try to explain what they focus on, I say, here are 11 things that could affect you. And where do you have gaps? And you have to look literally just one step at a time, just build, let's just work towards that. So I hear what you're saying, but that was a nice clarification, because my brain was thinking the mutation was going to be impacted by what was happening, but you're saying it's not quite like that. So that's,
well, and what it means is that we can potentially fix the situation.
yeah, which is even better, right?
Yes,
And that's what we want to do. We want to have actionable things. Another piece of homework I did in preparation for talking to you was a research doc you had done, and it was a review on low carb that you published in 2011, and it talked about metabolic syndrome and rather metabolic dysfunction was different in certain subpopulations. So I know it speaks to what we're talking about, but is there any additional meat on the bone when it comes to that study?
Well, what it means is that is that one size doesn't fit all. I mean,
Right.
That's the bottom line. And that I think that minority populations of color need to demand that. I mean, just as you would demand equal schooling,
That's right.
equal opportunities for employment, equal opportunities for housing.
Okay.
You have to demand that you not be treated
right
with science that doesn't apply to you.
And they have to believe they have power, because it's frustrating when the system, the lobbyists, the special interest people, even with the current election, it just seems like they kind of swooped in and decided who they want to run. And it's all like you feel frustrated. And then you have a ray of hope, and then they kind of squash it sometimes. So I think but I do believe that what you're saying is true. It's still a democracy, and we do have a voice, but most people just don't realize it, and they kind of give up prematurely. And I think that's our biggest enemy, is that lack of belief in what's possible,
Yeah. Well, and this goes back again to the clinic. The revolution needs to happen in the clinic.
Okay.
That we need to teach people who have been given a diagnosis of diabetes to demand, given the opportunity for remission and reversal. That they should not. It's like saying separate but equal, right? I mean, it is. It's like saying, well, if you go to a private clinic and you have your choice of doctor, you can keep around to find a doctor who's going to help you put your diabetes into remission or reversal.
Okay.
But if you're going to a public clinic, that's an overworked doc, fewer resources for that community in general.
Right. Yeah.
You have to go in there and you have to say, I want this for my mother, or I want this for my father, or I want this for myself.
That's right.
You have to ask for it, and but that means this is what you're doing. As far as I'm concerned, this is what the great thing that you're doing is that you're letting people know that they have the right to ask for this, that you're letting people know that they can demand this of their physician, of their nurse practitioner, of their dietitian, that they don't have to settle for years of insulin that they can't afford in the first place.
That's right.
Years of complications that will happen. It's not a matter of if, it's a matter of when.
Okay.
Loss of eyesight, loss of kidney function, loss of limb. They don't have to settle for that.
Imagine, and that's what's been the greatest gift. And again, I'm open to any dietary approach that'll clean up that metabolic dysfunction and will help people heal. But prior to moving towards a carb restricted model, people didn't have hope. And I've seen people with, some borderline kidney function go to normal. I've seen people who literally just heal within months and get off of insulin within a month or two. I know Dr. Jason Fong, they take people, it's rare that they take longer than a month to take people off of insulin who've been on insulin forever. People wouldn't think that was possible. And of course you do it in a structured manner and you have your clinical guidance. But yeah, I think that giving people hope and giving that back to them is like the greatest gift you can give people. And then as a clinician, I feel like $1 million, because when I go to this week, I'm thinking about, I just shared this with a patient. Every day except for today, I took somebody off of medicine. And on Friday of last week, I took 2 people off medicine. That never happened in my previous, and I'll probably have Dr. Andy Fung, Phung, not, the other Fung, the fasting guy, but he'll be probably on my next podcast. And he constantly, in fact, he just tweeted a success story today, and I, shared it. But, this is possible, guys. And although we're talking about a slightly off topic in a way, there is hope to heal from chronic disease. But I do want to go political one more time. And one of the things I printed probably with my health systems paper, but so, it is what it is, right? Don't get me in trouble. So the title of this paper I found that you wrote, it said, Food and Trumpiaism, how a farm crisis, food stamps, and fat-free diets foreshadowed a Trump victory. What the heck is this paper about?
So it's actually a chapter in a book that's coming out like right now.
Yay!
So, it's called Food and Conversations About Food. And this was a conference paper that I gave down in Lubbock, Texas. And it was really interesting to me because there was this back and forth in the Atlantic and in the New Yorker between Ta-Nehisi Coates and another writer whose name is escaping me right now. But basically, they wanted to make, the first writer wanted to make the whole Trump thing about class, the poor people versus rich people. Right. And Ta-Nehisi Coates is going, but it's America. Class is always about race. It can't not be about race, because how we get separated into different socioeconomic groups in America has a lot to do with race. And that's that structural inequality that I was talking about earlier, because we prevent people of color from building capital, from passing capital along. In that paper, it talks about how, yes, during the farm crisis of the 1980s, late 1970s, early 1980s, white America lost a lot of land. Middle class farmers got bought out by big farmers because they'd over mortgaged their land, and it's, all economics. And everybody, there was a big uproar about it. Mm-hmm. Nobody made a big stink about the fact that Black farmers have been losing their land for decades due to the way that our financial systems were set up and discriminatory practices throughout that sort of thing, where you would let white farmers get loans, but the same Black farmer with the same amount of income and land couldn't get a similar loan. So that land loss for Black farmers have been happening for decades.
Yeah, that's huge.
And it's huge because you know what? If you own the land, you can grow your food.
Right.
And so this, again, impacts health, not directly, but indirectly. So when the farm crisis came along and all of a sudden white farmers were losing their land at a rate that Black farmers had been losing their land, everybody has a big uproar about it. But what ended up happening is now those farmers couldn't raise their own food. Now those farmers had to go on food stamps in order to get, and now those farmers who were white had to eat that crappy food that the USDA had been feeding low-income minority people for years. And and so now they're going, what the heck? So this back and forth that Ta-Nehisi Coates was going on about is, this isn't just about class, it's about race, and it's about food. So when this white woman in West Virginia goes, I don't want them telling me what to eat all the time. I want to eat this stuff if I want to eat it. Yeah, well, like I told you earlier, the whole dietary guidelines began, or the dietary goals began with targeting minority, low-income populations because we wanted to tell them how to eat. Wow. Now that we were treating white people like that, they were upset about it.
That's right.
So the gist of the whole paper is that it's no fun to be treated like you're a minority.
No, population. Nobody wants to be treated like that.
Nobody wants to be treated like that. And Trump's appeal came from using that sort of racial divide to talk to poor white folks and basically say, we don't want you down there with the poor Black folks. We're going to lift you up, but we're going to leave them down. And that's part of what his political appeal has been for some groups.
Right, for some
other
people.
ways that he's appealed to other groups, but that was part of the appeal, and that's been part of our political history for ages. Did you know, I did not know this, but George Wallace, who's a horribly racist candidate for president way back when, the groups that were going to vote for George Wallace, if they couldn't have him for president, you know who their second choice was? Robert Kennedy.
What?
Yes. And what that was, now think about it. The same people who voted for Obama turned around and voted for Trump.
That's true.
And it's the same situation in reverse, but basically what they wanted was someone who was going to make things better for them.
That's right.
In one case, one person was promising, I'm going to make things better for all of us, and that includes you.
Okay.
And the other person was saying, I'm going to make things better for you, but I'm not going to make things better for these other folks.
That's right.
They didn't care as long as things got made better for them.
Okay.
You see what I'm saying? So
I hear you.
Yeah.
I wonder, so, we'll probably be wrapping up in a moment, but I know a lot of people who know me and they know what I message. It's all about reducing carbs, right? And I know we talked about clinical guidelines and how we need to let the clinicians help guide the patients. And now, so if you talk to the people in the low carb community, they would say, no, we need dietary guidelines that say reduce the carbs. And so I just want for this audience to hear you talk about why that's, not a good idea to put low carb into guidelines. And because, my personal experience, empiric evidence is that when I put people on low carb, things get better. We don't, and you would argue, well, we don't have long-term studies, and I'm definitely agreeing to that. So, but what's wrong with providing that guidance if it seems to impact the, probably 60-70% of the population is borderline or insulin resistant? So I need you to
but think about what you said. When I put people on low carb, they get better.
I did say that.
You think about that. That's you doing that.
Right. That's right.
Now think about if I read about low carb on a package, because that's how dietary guidelines get conveyed. They don't, how many people actually know what's in the dietary guidelines?
No, I doubt that they read them, to be honest with you. Yeah, they don't.
3 other people, right?
Right.
So, but we educate people through food packaging.
Right.
So when gluten-free was a big thing, nobody knew what gluten was, but they knew they didn't want it in their food.
That's right.
That's exactly what happened with cholesterol back in the 70s. Nobody knew what cholesterol was, but they know they didn't want it in their food. Same thing with saturated fat. We didn't know what that was, but we knew we didn't want it in our food. So all of a sudden, now we're going to have low carb dietary guidelines. One, those are going to be defined by the USDA and HHS, and I really doubt that they're going to define low carb as 50 grams of carbs or less. They're going to use
probably not,
because that's what they've always used.
Because all the studies are much higher. Yeah.
Yes, and we define low fat by a percentage. We don't use a gram count. We use a percentage. And so that's what they're going to do with carbohydrates. And if you think that telling people to reduce their carbohydrates to 45% of calories or lower and increase your fat, right, with no particular limit on it, and then we leave it to the food industry to educate the public about that, not you. So it's not you telling people, it's a package of low carb granola bars on a shelf that is made from wheat bran and soy byproduct and corn oil and has zero nutritional value except what's been put in there by sprayed on vitamins and minerals.
Right.
And you think that people are going to feel better and do better because they've been educated in this way of eating through those products? I would say just the opposite. I think there's good potential that will actually backfire because fat is so much more calorically dense than carbohydrate. So with when the low fat dietary guidelines came out, here's what happened. They told us, lower your fat and increase your dietary carbohydrate. Here's what we did. We increased our dietary carbohydrate. Now, if we give people dietary guidance that says lower your carbs and increase your fat, and people do this, increase their fat without lowering their carbs, people are going to get worse and not better.
Okay.
So there's all sorts of reasons, but to me, implementation is the biggest problem. When you are getting your information from even a well-resourced website like Diet Doctor, my employer, or you're getting your information from a clinician, you stand a much better chance of getting accurate information than if you get it from the back of a food manufacturer's box.
Gotcha.
So it's just how, again, this is my communication background, but that's how the information gets conveyed.
Mm-hmm.
And if we have people who are on medications, if we have people with with additional illnesses, if we have people who have bad side effects when they try to lower carbs, even if they do it right, we may still put people in danger. And
That's right.
and again, when you do it in your clinic, you're not doing it willy-nilly.
Yeah.
You're using this intervention with people that you think either have a strong family history of diabetes or metabolic disease, they have a personal history of diabetes or metabolic disease, they have some elevated risk factors, they're overweight. So it's not just anybody. You're giving a targeted intervention to a targeted population.
Okay.
When we put things in public health guidelines, we are just spreading it out to the world and letting people implement it however.
That's right. That's right. And I love that. I guess the last thing I'll ask you is the ability of us doing our clinician part, and then the impact, not just on the patient, but industry. So is it possible in an ideal life, I'm just being ideal, happy, positive about it. Is it possible that industry will follow? Because I didn't see cauliflower rice in the grocery store in the frozen section a few years ago. Now it's like cauliflower everything, right? So do you think that that'll move the needle and industry will follow? Or are they going to keep trying to force these cheap grain, the corn and the soy and the wheat, they're going to keep forcing that upon the population?
So I think it depends on what you're looking at. If you have people who are buying products because there's and food manufacturers who are producing product because there's a consumer demand, which is what we've seen with things like cauliflower rice showing up in the frozen food section. The food manufacturers will produce what the public demands. But in the case of dietary guidelines from the National Nutrition Policy, we're looking at a way to unload commodities.
Right.
And that's part of what nutrition programs do. They are a way to unload commodities. Right?
Overproduced items have to be utilized, so they're gonna just put it out there in any way, fashion they can. So it's never. So you mean to tell me all of this? When people see nutritional guidelines, they automatically think this is here to make me healthy, and what you're saying is this is here to help push maybe Department of Agriculture, whatever they need to get sold or support the farmers with.
I wish it were that clean cut. But the Farm Bill, which is what governs all of our nutrition programming as well as our agricultural programming, it's one thing. There's a great illustration on the web. It's the Farm Bill tree, and that's what it is. It's the Farm Bill is a big tree, and one branch are our nutrition programs, and another branch is the commodity things. And what the whole trunk of the tree is, we need to make sure that farmers are always producing food. Right. And in order to have farmers produce food, we need to make sure that they get paid.
Right.
And we can only do this through commodities. So you have people who should know better say things like, well, we should subsidize vegetables. Well, we can't subsidize vegetables because they're perishable. So we can't hold on to a bunch of broccoli until the price goes up. But we can do that with soy. We can do that with corn. We can do that with wheat. We can hold on to it until the price gets to where we can resell it and it's profitable for farmers. So that's what the commodity programs are all about. But if the government can't just resell it, the government can buy it from itself and resell it that way and make a profit that way, right? Or make a profit for the farmers that way.
That's right.
So then we have corn, wheat, and soy that we have to use somehow in our school nutrition programs. So it's not really, it's not like the USDA is back there going, whoa, we're going to create guidelines.
Right.
It was, however, when the dietary guidelines were created, they really did believe that these higher carbohydrate, lower fat diet.
And I believe that's true. They thought it was better.
Help. They thought they had all the best intentions. And it took about 5 years for food industry to go, Oh, so basically all we have to do is take our crappy commodities and just food science them
Right.
into something that meets the dietary guidelines, and then we can sell them and call them healthy. We can sell them to the school nutrition program and call them healthy because they meet those dietary guidelines criteria. You know, do you remember pink slime from a few years back? Pink slime was actually a highly desired byproduct because why? It was invented right around 1980 because it was the lean part of the meat. And you can take this lean part and add it to regular ground beef and make low-fat ground beef. And that's what we wanted. Consumers were begging for that in the 1980s. But then when it got reconstrued as pink slime and all of that, then no more. We didn't want it anymore. But it was designed as something that you could add to meat to lower the fat content of meat, which was something that was
I thought it had more to do to make it look like it's still fresh. I had no clue that it was that.
No,
oh my God, that's
it
crazy.
Was about getting the meat trimmings, separating the fat off of them, and using that lean meat as an additive to ground meat to up the lean content and lower the fat content.
Yeah, it's so funny because I'll be at Aldi's and I'm looking for the fattier stuff, ideally grass-fed, because who knows what it is if it's grain-fed, but that's a different way of looking at the world. So this is really insightful, and it really provides just another perspective, because when I talk about, you know, protecting your nest, it's a little more complicated than just eating right and reducing stress. If you don't kind of think about all of these factors in totality, then you miss things that could be affecting you. And sometimes I always remember the principal who retired on 3 blood pressure medicines. About 3 months after she retired, she came to see me, and I had to take off 2 medicines because it was her job. Yeah. It was the stress. So there's all these factors, and that's what anybody listening needs to understand. And while we're having, you know, thought leaders from a different perspective come in, even to challenge my dietary guidelines push, I want to be challenged. I want somebody to tell me, Doc, you hadn't thought about this. And so as we start to make decisions, and I'm so also thankful that you have the Diet Doctor information to share about how they can teach people. The resource they have for regular folk, I know they have the continuing medical for the docs and the nurses and the pharmacists, but for regular folk, Diet Doctor has some good stuff for them as well. Could you just review that real quick?
Yes, we have anybody who wants to start on a low-carb diet. We first caution them, if you're on medications, then you need to work with a clinician to help you adjust those quickly. But all of the information that you need to get started on a low-carb or a strict low-carb diet, which is typically what we call keto, is out there, and it's free. There are videos, there are guides, there are handouts. And for that matter, if you're a layperson and you're just really interested in this stuff and you want to take the CME, guess what? You can take it. It's free, and it comes with a lot of...
That's a good point. I hadn't thought about that.
You can. It's a little, you know, it's technical.
Yeah.
But if you just are interested in the science, it's referenced, very heavily referenced, so you can look up the studies for yourself. You can take as deep a dive into that rabbit hole as you want to. But there's lots of resources, shopping lists and meal plans and everything that you would need to get started safely and effectively on a low-carb diet yourself. And there is a find a low-carb doctor map. So if you want support, you can go and you can find those. And there's a group now, you have met some of those folks, called metabolic multipliers.
Yes.
And they are putting these resources together so that there's a one clearinghouse to find all of these resources. And so Diet Doctor has a map, but other groups have maps too. And so you're sure to find the help that you need to get support to reclaim your health. And that's what's important to me, is that everybody has the chance that my dad had to keep his toes until the day he died.
You just put a bug in my ear. I just thought about some as you were talking about metabolic multiplier, because I 100% just search that, guys, metabolic multiplier. But I'm going to definitely, I'm going to probably on my new website, which should be up in a week, or I keep saying in the next week, but hopefully in the next week,
Really
I'm going to put some links in my website as well to the CME for the docs, the education for the patients. I'm writing it down as we're talking. And also the metabolic multiplier, because you guys make my life easy. I'm seeing patients and things, and I want to let you guys handle some of that. I'm just going to be a champion and get the message out. So I really appreciate that. Definitely want to appreciate you, because we have spent a lot of time together today. So we did an hour-long podcast, and I'm looking at the clock here. We're at an hour. So I really want to thank you. And I hope that as people listen to this later, and for those who are here live, and I want to thank Harriet Boyd for doing a shout out, and B Green. She said it's awesome. And interesting topic came from Sherry Bay. And then Jasmine did a clap, and Natasha Jefferson just said good evening. And then Fred Du Bois just said, hey, Doc, great info. So I just wanted to do a shout out to them. And for those who are looking at the repeat, just understand that this is just half the conversation. Definitely check out that podcast. Will be out July 31st in your podcast app. We'll go a little bit more into those clinical guidelines that we kind of previewed a little bit here. And I just want to thank you, Dr. Hite, because I certainly plan to be attached to your hip, tell your husband that we're going to do some work again. Yeah. And we're going to keep doing this so we can kind of be champions for the cause. So I hope you have a wonderful evening. For those who are listening, share this video on Facebook and YouTube, and we'll continue to create content. Of course, subscribe to the podcast as well. So thank you guys. Have a great evening. And it was fun. And you have a good night, Dr. Hite.
Thank you. Thanks so much for having me. It's been
no problem at all.